Hi, my name is Dr. Shylesh Kumaran Aravindan, and I'm a consultant paediatric anaesthetist at the Royal London Hospital. I'm going to be talking to you today about the anaesthesia for paediatric neurotrauma, and I'd like to thank the North East London and Essex Trauma Network for access to their materials to create this lecture. I have also used some other sources which I will give you the links to at the end of the presentation. When we talk about anaesthesia for paediatric neurotrauma, I'll be talking about anaesthesia in all settings. This can be the emergency department, this could be inter-hospital transfer from one hospital to another, or even within the hospital from theatres to intensive care to CT scanner, etc., etc. Why are children prone to head injuries? They have disproportionately large heads and weak neck muscles, and that make them prone to head trauma. Their brains are also more prone to edema. When we look at the pathophysiology of head injuries, you have the primary injury, which can be direct trauma. However, what can also occur is secondary brain injury, and this is due to the development of edema, the disruption of cerebral perfusion pressure, a rise in intracranial pressure, or cerebral tissue hypoxia from increased cerebral metabolic oxygen consumption. What can be modifiable by anaesthesia is the secondary brain injury, and we'll look at the determinants of that and how we can manipulate them. The key thing is to avoid hypertension and hypoxia, and that will be a running theme throughout the presentation. But first we're going to talk about cerebral perfusion pressure, which can be decreased by hypotension. Cerebral perfusion pressure is the mean arterial pressure minus intracranial pressure. So systemic hypotension can decrease the mean arterial pressure and thus decrease the cerebral perfusion pressure. What you can also have is a rise in intracranial pressure, and that's due to a rise in cerebral blood flow. It's important to distinguish between cerebral perfusion pressure, which you need to maintain at a higher level to maintain tissue perfusion and oxygenation, and cerebral blood flow, which can actually harm perfusion pressure. To target cerebral perfusion pressure, we aim for, in newborns, 30 to 40 millimeters of mercury, in children 50 to 60 millimeters of mercury, and adolescents 60 to 70 millimeters of mercury. You either need direct intracranial pressure monitoring, which can be done via a bolt, or via intraventricular drain if inserted by the neurosurgeons. You may need to estimate the intracranial pressure if they have signs and symptoms of rising intracranial pressure, which may be decreasing consciousness or pupillary changes or the Cushing reflex. In order to maintain cerebral perfusion pressure, you need to maintain a higher blood pressure that is normal for a pediatric patient. And here are the list of them here. In a less than 1 year old, you need to maintain above 80, 1 to 5 above 90, 5 to 14 above 100, and greater than 14 above 110. I'll mention strategies a bit later on about how we can do this. You also need to avoid tissue hypoxia. One of those is by ensuring adequate oxygen delivery. Another way is to decrease cerebral metabolic consumption of oxygen. I'll mention which parameters affect those a bit later. If you want to ensure that the patient gets oxygen, you may need to intubate them. The indications for intubation are a reduced level of consciousness with possible airway obstruction. This is associated with a Glasgow Coma score of less than 8. Another indication for intubation is inadequate breathing or persistent desaturations. You may also get hypoventilation, and this might be a direct brainstem effect affecting the respiratory drive, or they may have other reasons for hypoventilation, such as an associated chest injury. There may be a loss of protective laryngeal reflexes. There may be significant facial or neck injuries, which means they cannot take in oxygen through the oro or nasopharynx. Seizures not only will decrease oxygenation by either airway obstruction or post-ictal airway obstruction or hyperventilation, but the seizure activity itself can increase oxygen consumption in the cerebral tissue. If you are going to intubate a child with a head injury for any of those indications, you may need to consider that they have a suspected cervical spine injury. It may even be confirmed. Therefore, you need to modify your intubation technique to allow this. One of the ways is by manual inline stabilisation, whereby you release the collar or any blocks that's keeping the neck neutral, and you replace it with an assistant's hands. You may need to use a videolaryngoscope, as you cannot overextend the head. When it comes to the choice of induction or maintenance drugs, classical teaching dictated that some drugs would increase intracranial pressure. Ketamine was thought to be one of them. However, we would advocate using the drugs that's safest in your hands. If that's propofol, use propofol. If that's ketamine, use ketamine. Just be aware of the effects of each of them. So propofol has a vasodilation effect, which can drop your blood pressure, so have a vasopressor or inotrope to hand. We generally now avoid succinylmethonium unless we know the patient has a rocuronium allergy, as that has been known to increase the intracranial pressure and increase the consumption of oxygen, particularly with the muscle fasciculations. We're now going to move on to how you maintain cerebral perfusion pressure. As I mentioned at the start of the talk, this can be applicable wherever the patient is, whether you've intubated them in the emergency department, whether you're transferring them from one area of the hospital to another, or another hospital, or in theatre, or even on the intensive care unit afterwards. In the UK, most anaesthetists and intensivists use the ABCDE schematic, so airway, breathing, circulation, disability, which we use as another name for maintaining neuroparameters, and E is for everything else. In terms of the airway and breathing, we want to maintain cerebral perfusion pressure, and that is by ensuring that we don't increase the intracranial pressure by increasing cerebral blood flow. What increases cerebral blood flow is hypoxia and hypercarbia. So we maintain saturations greater than 95% or a PaO2 of greater than 13 kilopascals. We aim to have the partial pressure of carbon dioxide between 4.5 and 5 kilopascals, and we keep the patient in a head-up position. And this is to encourage venous drainage to decrease cerebral blood flow. This is just a graph illustrating the effects of hypoxia and hypercarbia on cerebral blood flow. As you can see, with decreasing oxygen, you have decreased cerebral blood flow, and with increasing carbon dioxide, you have an increase in blood flow, all of which increases the ICP and decreases cerebral perfusion pressure. In terms of circulation, as I've mentioned in the slide before, you aim for cerebral perfusion pressure appropriate to age. Always aim for normal volemia. They may need crystalloid, or they may even need blood products if their hemoglobin is less than 7. More often than not, they may need vasopressors or inotropes. If they need a central venous catheter, don't place it into the neck, because that can occlude the venous drainage and thus cause an increased cerebral backflow of blood. Another important part of monitoring circulation is to monitor for Cushing's reflex. When the brainstem starts to herniate through the foramen magnum, you get a reflex bradycardia and hypertension. In terms of monitoring disability or neurological parameters, Always maintain adequate analgesia, sedation, and paralysis if you need to. A patient under light anaesthesia, or those that are coughing or moving, will increase intracranial pressure by increasing cerebral blood flow and decrease in oxygen and increase in oxygen consumption. Another part in neuromonitoring is monitoring the pupils, looking for signs of a third nerve palsy, which may be a sign of increasing intracranial pressure or potentially coning. Seizure control is very important. A lot of the literature talks of phenytoin, but in the UK we use levetiracetam. If they have signs of coning or signs of increased intracranial pressure, they may need hyperosmolar therapy. The two agents we use in the UK, and you may use them in the Ukraine, are mannitol of 0.25 to 1 gram per kilo, or hypertonic saline of 3 ml per kilo or 3% normal saline. As I'm sure you know, these are heavy diuretics, so expect an increase in urine output. With that, you may need to fluid resuscitate them, maintain their blood pressure, and you also need to monitor the urea electrolytes and their serum osmolarities. In terms of everything else, you want to avoid hypothermia. A hot patient will increase oxygen consumption. You want to nurse, as I've mentioned before, head up 30 degrees, and this is to encourage venous drainage. And the head to be in a neutral position, and this is to stop kinking of the neck vessels. If you're securing an endotracheal tube, use tapes instead of ties, once again to avoid obstruction of the neck vessels. If the patient does display either signs of high ICP, or if you're managing it, you can put in a few measures to decrease it. So go through an A to E fashion, make sure all the parameters are maintained. Often in our practice or in our center, it's because the patient has become light on the anesthesia or the muscle relaxant has worn off. Other steps you may do, if all of those things are maintained, is to hyperventilate the patient to less than 4.5 kilopascals on the partial pressure of carbon dioxide. Other aspects you may need to do are give hyperosmolar agents. There should always be a discussion with the neurosurgeons, who may ask for a repeat CT scan, or they may perform interventions such as placing an intraventricular drain, which drains off CSF, or they may perform a decompressive craniotomy. Very occasionally, if you take them to theatre for decompressive craniotomy in what you suspect is a very, what we call tight brain, so a head that has high intracranial pressure, there may be a rebound hypotension once they've lifted the skull off. So do be aware of that and prepare adequately. In summary, the goals of anaesthesia for neurotrauma is to prevent secondary brain injury by avoiding hypoxia and hypotension. You reduce hypoxia by reducing oxygen consumption or increasing the supply, either through intubation, ventilation, and either increasing FiO2 or the ventilator parameters. You need to always maintain cerebral perfusion pressure, and you do this by either increasing the mean arterial pressure by keeping the blood pressure up, or reducing intracranial pressure by reducing sudden increases in cerebral blood flow, as I've illustrated by manipulating the PaO2, the PaCO2, or by other factors. There are two pieces of literature which you can read, which summarizes a lot of what we've discussed in this lecture. We, in the North East London major trauma system, have a major trauma manual, which I will send to Irina and she can distribute to you. There is also what we call anaesthetic tutorial of a week, which is a document which lists the anaesthetic requirements for neurotrauma. If you would like help translating this into Ukrainian, I'm sure that can be arranged. feel free to email me, which I'll give you at the end. I'd like to thank Dr. Breda O'Neill and also the North East London and Essex Trauma Network. I should mention that Dr. Breda O'Neill is my colleague at the Royal London, who is our trauma lead. And as I said before, I got some materials from the North East London and Essex Trauma Network in order to create this presentation. If you have any questions, comments or feedbacks, you can email me at this address and I can work with Irina to help you answer them. Thank you.